We are also joined this morning in the hot seat by the Nyeri Deputy Governor. This is Dr. Caroline Karugu. Thank you very much for coming. Asante sana and karibu. It's not often that we also see a guest coming in bearing gifts. Are those for us?
Oh. I've been looking at that coffee, actually.
You're holding something in your hands.
You know what happened?
You don't go anywhere empty-handed.
We are villagers.
You were raised well.
Yeah, I'm raised well. Right? I came and they asked me, what should we offer you? And I said, some black coffee would be great. And they brought coffee that is not really coffee. And I said to them, you know what, I want you to understand coffee because what you're serving here is actually what we call coffee mud. What is left in the drum after we mill the nice roasted coffee, we put water in it, and then we make this expensive Nairobi coffee. So I told them I usually will carry a packet or two in my trunk. So this is some nice Nyeri coffee done by the Dedan Kimathi University. My treat to you all this morning so that you stop serving this horrible coffee.
The aroma in the studio, it's amazing.
Precisely. Okay. So, yeah, but they said they don't have a coffee machine. I think I'll have to donate that one.
Wow. That's true.
You should come more often.
Yes. This is why we need women in leadership.
Exactly.
See? The whole concept of not going empty-handed is actually, being exhibited here. So, asante sana, Madam DG, for coming. All right, so here it is. If you can zoom in, John, into this, and someone can see this, what I'm holding. 100% Arabica coffee, medium roast. Dedan Kimathi University premium coffee. Right? Very beautiful.
Talking about
Beautiful
creative
packaging.
income revenue from cities or towns.
From counties.
From counties.
Is it available in our supermarkets?
And you know what is beautiful about it? They go into research for coffee. It's a university, so it's not 100% commercial. They spend a lot of time in researching the new clones of coffee, how to roast and mill good coffee. So it's good coffee. Taste it.
Fantastic.
Yeah.
Now tell me, good morning.
Good
Do you charge parking fees in Nyeri?
Yes, we do. We haven't hiked them.
Okay.
We haven't hiked them, but yes, we do. Yeah.
Okay.
In keeping with African traditions, we're being very un-African here. Here we are pounding you with questions, and we even haven't asked you to tell us a little bit about yourself.
Absolutely.
And how you got into politics.
Or even how is Nyeri and how is
And how did you travel? How is the weather? Yes.
Let's start with the
Nairobi
traditional
children.
African
It's
greeting
okay.
city.
Yes.
How are you? How are the children? How's the family?
Okay, Daktari, how are you?
I am well, thank you. And
That
thanks
is
for
wonderful.
having me. The
Yes.
children are great.
Yes.
Everybody is great.
Yes.
We are enjoying good rains in
Yes.
Nyeri,
Yes.
and we thank God for them.
We also thank God for having you here. And how are the people of Nyeri?
The people of Nyeri are good. You have seen we are quiet, we are good, we thank God. All is going on okay.
Yes. The BBI notwithstanding, you're all well.
We are all well. We are reading the BBI. That's why we are quiet about it.
Yes.
Yeah.
The title that Eric has presented us with is Doctor.
Yes.
Tell us what it is that you're doctor of.
Oh, I see. Yes, I am Doctor of Finance.
Yes.
I speak a lot within the medical space, and people tend to think I'm a medical doctor. I am PhD Finance from a collaboration of USIU and the Columbia Business School in New York.
Fantastic.
So,
Excellent.
Yes.
And how did you get into politics? How did you move from the world of finance
it's-
into these very murky waters of politics?
This
It's
journey.
something I have really thought about this morning when I was trying to come to studio. And, I was driving and I kept telling my driver, we need to get there at 8 o'clock. But we don't need to die getting there. We have a bad precedence with coming to studios in the morning because our late Dr. Nakuru, died trying to make it to your studio deadlines. So, that is how I got myself into politics. I had been supporting politics from what I like to call row number 4. So I was a row number 4 politician, crunching the numbers, beefing up the manifestos, and really have been happy to support from the background because then I was actively in corporate Kenya, and of course it's a no, you cannot do the two. And I guess that when Dr. Gakuru died, the natural thing was to be brought from row number 4 to row number 1.
Row number 1. Quick fast.
So quick fast,
and
quick,
prepared.
very quick, very quick fast.
You're
And
going to tell
I was
us
a
that
bit
story.
hesitant about it, but yeah.
Let's go to the top of the hour and then take a look at what's happening on the roads. And then, of course, you'll tell us that story of how you got there and your experience so far.
Right.
We have in the studio on the hot seat Dr. Caroline Karugu. She is the Deputy Governor of Nyeri County. Of course, we'll be having a conversation with her. Nyeri County is one of those that were piloting the Universal Healthcare Program.
Yes.
Of course, we want to hear what they've been doing about that. Also, Nyeri County has had very many cases of cancer and other non-communicable diseases. She talks a lot about health and she says that. So we'll throw her into the deep end on that. I'm sure she'll swim on that particular topic. Of course, we'll also talk a little bit about Nyeri politics in the region. Broadcasting from Nairobi on 94.4. We are in Mombasa, Kisumu, Nakuru, Eldoret, Nyeri 90.9, Malindi 97.7. We are also live streaming on Facebook, Spice FM KE. We are on YouTube and also on our website, www.spicefm.co.ke. Our guest today on the hot seat, who's come bearing gifts, is the Nyeri Deputy Governor, Dr. Caroline Karugu. And of course, before we went into take a look at traffic, you were telling us about, your ascent into the position of Deputy Governor. Of course, then we started with the tragedy, and the Deputy Governor then became the Governor, and he had to pick Deputy Governor. Yeah. And this is where you came from 4th row to second row, is
First.
Second row. Yeah, second row. Let's just say second row. Yes, so, and, of course, the transition has been quite something. Corporate Kenya and politics are like two totally different things. But my approach to politics is really service. I look at it more as you're a civil servant. You are supposed to pretty much be real servant leader, so to speak. So that has kept me going. And every day learning new things, learning political dynamics. And I must say, I'm loving it. Yes, it's got to be done. Listen, guys, it's got to be done. All of us cannot sit up in ivory towers and not want to know what's going on in the grassroots. That is part of the problems that we have in this country. We have people who are very unwilling to serve and just very willing to be active on Twitter and Facebook to criticize what government is doing. So when opportunities for service come, I think I would like to call upon those of us who are technocrats to really, toss yourself into it and learn, swim with the sharks, and then soon enough you get your own space and you get what you're working for, and it's pretty enjoyable actually. Yeah.
So when you came in, of course, from your background in finance and what you were doing in finance,
Yes.
Maybe the other people in the county government expected you to focus a lot on finance, and then you come in with this other social agenda.
Well, I would say yes. In fact, the rumor in Nyeri initially was that I was going to be CEC finance, and really I didn't want to remain in the back office, with finance, because the need on the ground is real. And for Nyeri, I think there's one big need, and the need is within the health space. If you look at national statistics, we rank highest in prevalence of non-communicable diseases, to be specific, diabetes, hypertension, and cancer. And, having come from corporate Kenya, where we are tasked with the responsibility of finding solutions, that became the low-hanging fruit for me and the place to start, service from. I mean, I did a tour to, for instance, our County of Harrow Hospital and, pretty much the government hospitals. And, it was sorry. The state is just sorry. I spent like 2 nights, I really couldn't sleep. And my mother started asking me, why did you take up a job that's going to eventually kill you?
Right.
But how did Nyeri acquire this status? How is it that you then have the highest rate of non-communicable diseases? How?
That is the $1 million question. And you see, part of the problems we have in the health space is data. We've been very poor in data collection at a national level and also at a county level. The national government used to collect data before devolution. Post-devolution, that conversation went all over the place. When governors now became in charge of the health space, I mean, they had everything on their faces. You had to worry about drugs. You had to worry about the human capital. So issues, data collection, and research and analysis then took a backseat. So that is why we are where we are. I cannot tell you why is it that Nyeri is high in prevalence of. I cannot authoritatively tell you because I haven't seen empirical studies that then can inform my notion. However, we suspect a couple of things that. When I speak to doctors, they tell me maybe Nyeri is a little bit more affluent, being the former provincial headquarters for the Mount Kenya region. The affluence levels are a little higher. When I go on the ground, I'm not entirely convinced. There's also a notion. There's also a notion on the amount of pesticides that are in our food produce. Of course, all these are suspicions, but we need to exact them into research so that then we can conclusively say what could be leading to the non-communicable diseases. But it is true, if you look at even the amount of patients that we are seeing in the county, those are the three diseases that we are fighting every day.
Would you say that the people of your county have good health-seeking behavior? I come from a research background.
Yes.
So why I'm asking is because sometimes the figures are what they are because more people than perhaps in other countries
are reporting.
Yes.
Right.
So that's why you have the figures. Others don't report, so you don't know the figures.
Like I said, it's all out there. I mean, we need to invest in research in the health space. That could actually be one of the reasons. I remember I went to a meeting at the Ministry of Health, and they said they were giving rates of immunization, and Nyeri really ranked high in immunization. And other counties were arguing maybe it's because Nyeri has a better reporting structure. So then if we report, then it's more accurate. So the issue of data collection is really lacking in the health space. The issue of even data that speaks to each other that can then be able to inform policy or inform strategy going forward is also lacking. And this is where perhaps I call researchers like yourself. I'm glad you said you're a researcher. We need a lot more people just plugging into the counties and saying, I am here to help you research on ABCD. We have universities countrywide. I'm not entirely sure that we are speaking to each other with.
Actually, our universities unfortunately do not focus on research. Right across the country.
Right across the country.
Yes, they do not focus on research at all.
There were agreements between countries. And I think we can point to certain happenings on the continent whereby there was agreement to look at a certain percentage of national budgets towards health, towards research towards this kind of thing.
Yes.
I think we're scratching the surface at 4% nationally.
I know.
You see, so I mean, even that.
And the percentage was supposed to be 15.
It's supposed to be 15.
Yes.
And so even that with the resolve at a national level to actually have that as part of the big cake is wanting. So how do we, if at the top, because we always say from the very top is where the responsibility should be taken. Precisely. How then do we convince the people lower down on the rung to say, come in and plug in, where at the top there's no will, or we can't see evidence of a will to actually have that done?
What you're saying is actually very accurate. We have even a PS in charge of planning, and if you spend time with them, you get pretty depressed about where we are going as a nation in terms of understanding, getting an in-depth understanding of our issues. And the truth is, like I told you, post-devolutions, the governors were up to the neck with issues. All of a sudden, you had to handle your hospitals. All of a sudden, your nurses are on the streets. The doctors are on the streets. You don't have drugs. So it got to a point, as a manager, you begin to prioritize. Do I start researching on why we have cancer, or do I first ensure that we have
treat those who do?
Precisely, So in that game of balancing and prioritization, unfortunately, research has fallen through the cracks. It gets lost, and we hoped that at a national level, now that the burden has been carried by the counties, that it frees up space for the national team to actually now delve down into research. I do not know, and I cannot authoritatively say that is currently happening. I hope it is happening because the need is actually real. For instance, for us who are a pilot county, sometimes we are asked, can you give us records? And we say, we can give you records of the piloting phase between January and perhaps, October. But we cannot, the data before that is a mambo jumbo. It's everywhere, and we might spend another 3 years just trying to piece it together. So there is a need for research, and I think that is the future, because we are screaming about the same things as counties. When we meet, we all cry about, we don't have enough human capital, we don't have enough drugs. But drugs to go to who? What ailments are we treating? What amount of drugs does Kenya need? Issues telemedicine, which is the future. Instead of crying that we don't have enough nurses and doctors, are we looking at how to instill systems and how to incorporate IT so that telemedicine becomes real? Telemedicine.
What's that?
You don't need to have a doctor going around, seeing one patient at a time. I see a future in the space of medicine, and seeing the need that we have on the ground, that the doctor doesn't actually need to leave, even, to perform operations, that the doctor doesn't need to leave his desk. He can have 2-3 screens where he's able to interact with his patients from across. It doesn't matter where you are. You're in Nyeri, you're in Pokot, you're in wherever. A doctor should sit in Nairobi and be able to see those patients and be able to treat those patients. That way we are creating efficiencies on time, and we are also spreading the resources that we have, because I do not think that we have optimized the current human capital that we have. I mean, and there's also some low-hanging fruits. We have KMTCs everywhere. Today we just said there's a graduation. It's going to be about, I don't know, 1,000 KMTC, graduates.
Yeah.
Where do these people go? We are struggling with human capital. In my view, the students in KMTCs should have a day or two to help in the counties, to go and plug into the primary health systems.
Right.
Because if you look at what the countries that have really succeeded in healthcare, they have been serious about strengthening their primary healthcare. I mean, the dispensaries, the community health extension workers, the community health volunteers, those at the very village level. That is where healthcare, we must start to speak seriously about healthcare. And then we must also, invert the conversation from curative to more preventive. We have no business getting sick, and that is what I have been, that is my campaigns in Nyeri County have been. All these diseases that are ailing us are hugely preventable but not curable. That's what the doctors are telling us. So you don't need to wait until you have diabetes. You don't need to wait until your blood pressure is, uncontrollable.
You can deal with it before
You can deal with it before that. You can make a few lifestyle adjustment changes or changes, and you can live longer, or you can delay those diseases. So concentrating more on the preventive. Now,
Why
if you
is
look
this
at
issue not being amplified at the Council of Governors level? Because that's the caucus that should be talking about this. When we hear the Committee on Health at the COG, they're just talking about payment of workers. Workers have gone on strike. We're negotiating with the workers. Why not such conversations?
Like I said to you, governors are up to the neck with issues. And sometimes, the work of a governor, I've watched some of them, and they're just pretty much firefighting from this to the other. From this, by the time you're done with your health workers, the nurses also give you a notice when you're done with the nurses. The clinical officers want to. So we need a very sober conversation, or they need to relegate that conversation perhaps to their deputy governors and say, think strategy, think research. But with politics, I say with common sense makes perfect. Makes sense. But with politics,
I was coming to that actually.
What is
Yes.
wrong? Oh, sorry.
To your experience as a woman in politics, having come from the corporate world, and then you said you were swimming with the sharks. What has your experience been as a woman in politics?
How much time do you have? I can talk about this for 2 days.
What do you feel were the main challenges, first of all, and what do you feel you achieved as well, and how did you go about it?
First, the main challenges are just you're a woman. You're
patriarchy.
a woman. Yes, yes, the patriarchy. You're a woman, and therefore you are sort of undeserving to a great extent, and and you will not be able to make rational decisions. So there's that's the perceptional issues. She'll bring emotions into this. This is about politics. This is about decision making. Don't bring your heart to it. Bring your mind to it. And I say, you need both the mind and the heart when you're serving people. So challenges are pretty much more perceptive than reality. They will look at you and say, you can't. There's also cultural issues. Some people are very, edgy about why would a woman lead us? A woman traditionally was not supposed to be a leader. They were supposed to be a follower. When did this change? And you really feel it, especially when you're in the grassroots, when they begin to tell you those days of Gikuyu and Mumbi's work was this and Gikuyu's work was this, and that is why you're undeserving. But also, let me say, women have really matured into leadership, and women have I like women in leadership because they're almost activists. When I became deputy governor, Charity Ngilu had a meeting with me, and she said, you must be strong. You must, and we're going to hold your hand, and they're going to intimidate you, and you must look them back in the face and tell them, I am not here because I don't deserve. I deserve it, and I am here. And guess what? You're going to have to deal with it.
Brilliant.
And then likes of Jokindungu called me and said, I want you to do one thing. I want to take care of your mental health, because women in leadership are struggling with mental health. Yes.
Encouraging words, actually, to hear that women leaders are even, coming up and saying, coming to support and work together.
Yes.
Dr. Caroline Karugu is the Deputy Governor of Nyeri County. She's joined us this morning. She's come bearing gifts. We'll be showing you those gifts. This is some brilliant 100% coffee from Nyeri County, done by the, which Kimathi
University.
Well, we'll tell you how it tastes. Let's allow her to have some coffee that we have served her.
Mud.
So she calls it coffee mud.
Yes.
We have served her some what we call sumptuous coffee. She calls it coffee mud. Let's allow her to have a sip of that, and then we come back and continue the conversation. It's 18 minutes past 9. This is the Situation Room, Kenya's biggest conversation.
Spice up your life. 96.1 Spice FM. Kisi. Mature, intelligent talk every morning. Spice up yourself. Mornings done right. 94.4 Spice FM, Nairobi.
Recently, the papers reported that what was formerly Nyeri Provincial Hospital went into a collaboration with Kenyatta National Hospital.
Did they?
It was actually Odaya. It's Odaya.
Oh, no.
Nyeri.
I don't know. I'm saying it's Odaya. Odaya is in Nyeri. Yes, I know where I'm coming from.
Okay.
Yes.
Continue.
Now, how did that happen and why? And then I'll explain why I mentioned Nyeri Provincial Hospital, former Nyeri Provincial, and not Odaya. Yes.
Well, I didn't catch that one for sure, but I would imagine, Othaya is actually a level 6 hospital. Nyeri Provincial, as you call it, we call it the County Referral Hospital, is a level 5. So level 5s and below belong to county government. Level 6s were still left with national government. Why they would have a collaboration, I do not know, because I thought it was natural, that of course level 5s are supposed to have a natural, relationship with level 6s for purposes of referral. Maybe it's they want to say that finally Othaya level 6 is up and running, and maybe they wanted to hype that, but it's a natural relationship between level 5s and level 6s. Now, the thing is, there has been a huge influx of patients in our PGH, as you call it, the County Referral Hospital. Post UHC, we saw a lot of people getting excited about seeking for healthcare. We've also seen a season of our neighboring counties facing huge issues in the health space. Like Kipia had been down for a minute. Kirinyaga, let's not even get started. Muranga is struggling. Nyandarua is okay, but so we have a huge overflow of patients from our neighboring counties into our county referral hospital. Of course, there are perceptional issues of the fact that the county referral hospital at Nyeri is where the doctors are seated, is where you get quality health care. So that still runs until today.
You've understood. Now, which of these two hospitals sees most patients?
The level 5 or the level 6?
The level 5, of course. The level 5.
So how is it? What determines the levels? What makes one hospital level 6, the other one 7, and the other one 5?
The amount of amenities that are there. So level 5s are supposed to see the more complicated, issues
that are referred to them from,
yes,
say, the
from the sub-county hospitals, downwards. Level 6s are, pretty much for chronic acute illnesses. That is the ideal position. Unfortunately, that is not how it works, and that is not how it has worked historically. And that we are seeing that is part of the reason why we have a crisis in the healthcare system. It has been dysfunctional from the primary level. You see, if a properly functioning system, if I fall sick, I should go to the dispensary in my village.
Yes.
And that dispensary, if it's something they cannot see, is supposed to refer me to the health center.
Yes.
The health center to the sub-county hospital, the sub-county hospital to the county referral hospital. Now, but what we see in the villages, there are some hospitals that are known. This is where the doctors are seated. So if I, for instance, am sick today in Nyeri, I wake up and I go straight to the level 5. So if you go to our outpatients, even right now, you meet 200, 300 people who would have ordinarily be seen at the dispensary.
And are the dispensaries empty?
The dispensaries are empty for many reasons. One, for a long time, our dispensaries have not had health workers. They've had one nurse who opens maybe Tuesdays and Wednesdays, and the other days they're reporting and it's closed. And God knows if that nurse falls sick, the dispensary is closed. And people generally knew you will not get medicine there. And these are some of the things we are trying to redo with UHC, because UHC is about, I had Eric calling it universal health care. It's really not care. It's universal health coverage. In fact, we argue that care and coverage are inversely, related, and we can have a discussion about that. But we're trying to reverse this and, dissuade people from the notion that if I'm sick, I go to any hospital. So we are trying to regularize the system. If you're sick, go to your dispensary. So we're trying to add the health staff. With UHC, we've been able to top up about 230 new health workers, for instance, for Nyeri County. We're trying to say where we have one person, one clinical officer, let's have a clinical officer and 2 nurses. So that way...
Per what population or per what geographical?
Per dispensary.
And how many dispensaries per person, so to speak, or rather how many people to a dispensary?
The WHO actually does have a recommended rate of 1 to 14. I mean, and that is, I can tell you, we are
very far.
Oh, we are extremely far from making that target. But what we are trying to do, because it's baby steps. First of all, can we have the dispensaries open Monday through Friday? Can we have somebody sitting in the primary facilities seated there Monday through Friday? 2, can we ensure that we have drugs, at the very primary level? Because there are people, for instance, who are hypertensive, diabetic, who usually will wake up and go to the level 5s to pick their drugs. So one of the things we've been able to do in Nyeri under the UHC program is to devolve this medicine to the dispensaries, to the very, very primary level. If I'm diabetic and I need a refill every month, I can walk to the dispensary and get my refill. I have no business going to queue at the county referral hospital, trying to decongest. But I can tell you, it's baby steps. We are 1 year into it, and we haven't really gotten the 100% hang of it, but it is somewhat, working. Even, more the perception issue, telling people you have your drugs at the,
that's
at
what
the
I was gonna
dispensary
say,
level.
The communication part of it seems vital in the proper operation of all of this.
Precisely.
Because how are we going to tell people that you should go to your dispensary first if historically for them, the nurse only shows up on Tuesday and Thursday. And so now here's a directive saying, go to your dispensary when I know for a fact that there's nobody there. So you see the kind of clash when that information comes through.
Yes, precisely.
So unless these individuals are, like you say, stationed there, the health workers there, there's medicine there, drugs are available there.
I know.
Then now you're passing on that information. Then people get more comfortable to then be able to go.
Precisely. And I said it's a journey. It's a journey that, in my view, just has started with UHC. And I like to thank the president because UHC really, I think, is transforming the lives of our people. You know, we are struggling with, you know, regularizing a whole lot of issues. I mean, perceptional issues and the real operational issues. But I think that we have our best days, still ahead.
What funding model is the UHC using?
Currently, at a national level, they're sending monies to the county.
The government is?
Yes.
The national government?
The national government is sending a total of 789 million, for instance, to the 4 pilot counties. I mean, like to Nyeri. Yes, thereabouts, 700, 800, about, let's say about $1 billion shillings.
We heard a declaration yesterday from the president that quite a huge amount of money was going to be dispersed specifically for this year.
This coming year.
Or before the end of 2020 is what we're looking at.
Yes. And you see, this money doesn't actually come to the counties. It's not the money that comes to the counties now. that's about 60% of this will go to KEMSA, and then we draw drugs. Because the UHC is supposed to ensure that we have drugs. It's about affordability and access. Yeah. So when you speak access, you speak human capital. When you speak affordability, you speak essential drugs and the availability of those drugs at the very primary level. So KEMSA, is given that money, and we draw from them drugs, which in my view has worked very well. I think had counties gotten that money, we would have, challenges with, procurement and, I think it would have been misappropriation and whatever accountability.
Yeah,
issues.
You said the best days are ahead for UHC.
Yes.
So is this going to work? Because that has been the question for a lot of people. I mean, whether you look from Isiolo to Nyeri to Machakos, people are asking that question. Is this system for health coverage in the country going to work?
It must. We don't have a choice. I don't know why people debate about UHC like we don't know where we are coming from.
I asked about the funding.
Yes.
Is it sustainable?
Over time.
Because right now you have 4 counties. It's a pilot. There's funding for it.
$1 billion per county.
That's why I asked the funding model, because the funding model would be able to inform us of the sustainability of it.
It's 1 billion shillings per county.
Where's that coming from?
If we scale it, it's going to be 47 billion. My bad, sorry. 47 billion shillings in a country where dams money 60 billion disappears. I mean, come on, guys. You cannot. I have refused to plug into a conversation of whether it is sustainable. We have seen lots and lots of money disappearing in this country. Even if we put it in the health space and it disappeared in drugs, or there was some pilferages here and there, we would still be achieving a better goal than that money disappearing in total.
Your Excellency, theft seems sustainable in the country. That we've understood.
And that is why we are saying, if money is being stolen, let us the one that is left behind, can we at least
sort out
spare some for health? So I do not think that 47 billion shillings is a lot of money for this country. It is not.
My question was actually, you've answered it. You see, when you say the national government is going to fund it, then understandable. It is something that will be budgeted for. The money will be put aside,
and it has already. If you listen to the last budget, there's a
they allocated money for it.
They allocated money for it.
Did.
So I have no doubt that we will scale UHC. What I am nervous about is the expectation, because there's also this notion that UHC brings free everything.
It's free.
It brings free everything. Even drugs, everything is going to be free. But now that we are a pilot county, I can tell you it's the essential drugs. And if you cover the essential drugs, then you cover the indigents. when we were registering people at UHC, we wanted to find out, and we researched on who are the real indigents, who are the real needy of the needy, who require free healthcare. Yeah, and you will realize it's what 40, for instance, in Nyeri is about 40-50%. To the maximum. A lot of people have their own insurances. A lot of people are with the NHIF. So we wanted to establish who can really not afford. These are the people the government must have a conversation with and must afford healthcare too. So that needs to happen in the other counties. The other counties that haven't started UHC, if I was going to advise them, start regularizing your primary health care system, start getting your community health extension workers in place, your community health volunteers in place, get your dispensaries at least connected to water and electricity in the very minimum. Begin to prepare yourself for UHC, because UHC is really going to be looking at the primary health care and strengthening that health care.
Let's take a look at the traffic. When we come back, my first question will be, have you had a conversation with the other counties, the other 43 counties, county governments, and given them your experience with the pilot of the UHC program? We have Dr. Caroline Karugu. She's the Deputy Governor of Nyeri County, one of the counties that has been piloting the Universal Health Coverage Program. Kenya's biggest conversation. It's the Situation Room on Spice FM. My name is Eric Latif. We have C.T. Muga, Jerry Thorn Nduoko, and on the hot seat this morning is Dr. Caroline Karugu. She's the Deputy Governor of Nyeri County. We're talking about the Universal Health Coverage Program. Of course, we know that Nyeri County was among those ones that are piloting it. You've said you'd like to give some advice to the counties that have not piloted it, that are going to be, of course, rolling out countrywide. A couple of things. Ensure that you have electricity connected to your healthcare centers. Focus on primary healthcare.
Right.
Has the program actually organized fora where you 4 counties sit with the other 43 counties to tell them this is what we've been doing?
We, I think twice a year, we'll have a forum with the other counties. The last one was held in Kisumu. The previous year, we held it in Nyeri, where we call all the other counties and we say, this has been our experience, and this is what you must begin to do to prepare yourself, for UHC. When we were, earmarked to pilot UHC, we went around, and first of all, the number one thing is that you need to establish where your dispensaries are. I know it sounds ridiculous, but you would ask, how many dispensaries do we have? 190. No, I think the other one was open, then it was closed.
The other one in remember?
There's one that was open, then it was closed. So first establish how many at the primary level, how many facilities do you have in total? How many of them are connected to electricity? Speak to Kenya Power or whoever, get your facilities connected with electricity. And electricity is key, because if we are thinking immunization, you need at least a small refrigerator, to store the drugs in the very least. Water, reliable, clean and safe water is another conversation. They might sound like no-brainers to you all, but I can tell you in the village, that's where the conversation of UHC begins.
Right, I'm listening to you, and it actually does sound like really basic stuff. But as you say it actually then does make sense.
Yes,
because we've heard about UHC and talked about it, and some of us have had the opportunity to actually delve in it a little bit deeper.
Yes.
However, it just seems to be, for so many people, including some government officials, sorry to say, it seems to be shrouded in some kind of ambiguity, and people are wondering, okay, where is it that we are going to start? But as you say it now, it is some things are quite basic in terms of what is needed.
Yes.
And that seems to be the case within a lot of things when it then comes to governance, that if you start from the nitty-gritty, then you'll be able to actually sort out a host of problems that we're dealing with. Is that what you see?
Analysis paralysis is a problem, especially in the health space. I don't know if it's because most of them consider themselves extremely genius, and they want very complex solutions. When the UHC conversation was started, we started looking at models world over, why UHC hasn't worked in these countries. And I said, we don't need to have UHC the way it is
modeled
perceived
to other countries.
We can have UHC Kenyan style, just like the way we say we can have democracy the Kenyan way, we can have UHC the Kenyan way.
Jerry, did you hear that?
Because, because
democracy, the Kenyan way.
because the minute you begin to look at why UHC has failed in other countries, you first of all, you are not addressing the current need on the ground.
Right.
And the need is extremely basic. Do you have community health extension workers? The kind that you will charge with the responsibility of doing a door-to-door every day, collecting data for you, helping you in data collection, helping you do the very basic triaging, checking people's blood pressure and keeping the records in the home. That is where it is extremely basic, in my view. But it's been made complex because, also the health space is a big cash cow for many people.
Right.
So the more complicated you make it look and the more superfluous and impossible you make it look, then we revert back to the older system where a few mafia were, were eating the cake at the expense of, our people. So in my view, it's extremely basic. Primary health care, those dispensaries, those health extension workers, the community health volunteers, and concentrating on the preventive, promotive side of things. Putting money aside deliberately, because money is never put aside, even from a national level, for preventive and promotive. A small little budget, they'll do that, and then they print big T-shirts and many flyers. T-shirts say nothing to Wanjiku. If you come, I saw a huge campaign recently. They had printed T-shirts, and I said, if you took that money, instead of printing T-shirts and flyers and having loud vehicles going around the villages saying nonsense, just give us money to strengthen the primary healthcare system. Tell us how you would be able to add our staff in the dispensaries.
Why doesn't that message get? Because and this is replicated across the board, whatever sector of government or governance you want to look at. Why doesn't that message get in? Why? Because you can see I'm irritated, but why doesn't that message get through?
It does, but I told you it's a cash cow, and people are pulled in different directions, and the more heavyweight side of things is that draws you more money.
Where the money goes.
So those that make sense, perhaps are killing the cash cow for many other people. So the voice will be lost somewhere. But the idea is not to give up. The idea is to continually have the conversation. Just the fact that the president took UHC as one of his legacy items is one indicator that the voice could be reaching the top.
Yep.
That the problem that we're grappling with, the healthcare, are reaching the top. The in-between is what needs to be sorted. And that is why everybody needs to plug in.
Right.
The county governments need to plug in and consistently, give out the message of, let's regularize this system. And in my view, it is not complicated at all.
WHO, UNICEF, and other funding agencies came together to, first of all, research on something that was called ICCM.
Yes.
You know about the ICCM. And the findings were actually, it's a pet subject of mine, so I bring it up very often. And the findings were actually fantastic. And the findings were, one, that hospital attendance could actually be reduced by something like up to 75%. And what they were doing was training these healthcare workers, training them basically in diagnosing malaria, diarrhea, pneumonia, maybe in children. And they took it a step further. Within that particular setting, they would even have individuals who would actually provide basic medication once the diagnosis was done. Of course, major uproar among healthcare providers who are trained, specifically medical doctors. But what they found was that diagnosing it was not as difficult as people imagine. And even training people to understand it isn't as difficult as people imagine. You're not talking about any other disease except those three. Now, what it therefore means is you then decongest the health centers
Facilities.
And all. Yes, you do, because if someone's condition worsens, there's a process. You then take them maybe to a dispensary. If it worsens, then you take them to, say, a sub-county hospital like that. It worked. But just ensuring that these health workers who were part of this research process, who were paid by the so-called funders, asking county government to take over these healthcare workers was a challenge.
That's where the problem lies.
No, it's not the problem. It is a problem. It isn't the problem. The other problem was, has been the resistance of medical doctors specifically at the very beginning to understand that people who haven't gone to any institution to be trained in healthcare matters can actually look after healthcare. That was a hindrance. There was, I worked in this particular, I worked in HIV and AIDS care and treatment for 17 years. And because of the limitation of resources, this approach to healthcare through just lay people taking care of people, we found what we call a clinical and community health care assistant. We call them a CHA. The biggest fight we had was from the provincial office at that time, before it even became county, saying, they said, no, you can't have people. And we said, they don't treat anyone. They count drugs. They count. They don't just count it. And they do basics. They take the height, the way, basics. There's nothing clinical that they do.
But somehow I can see where the challenge would come. Why would they resist it?
Why?
Because everybody else in the village starts looking at this person as a doctor.
Yeah.
And this is the perception from the village. Is
if you sell sausages and you're wearing a white lab coat, you will be called a doctor.
Chef.
All right?
You sell sausages.
Did you say chef?
You're
Yes.
called a chef.
So, but in a hospital setting, everyone who is wearing a coat is called a doctor. If you're a lady, you're called sister, meaning they assume you're a nurse, even if it is you who is a doctor. So those are perceptions that we live with. The point I'm making is this. The solutions are not difficult to arrive
Precisely.
But how do you overcome the resistance? That's really what I'm trying to say. Because the resistance is what hinders it. It's not that we don't know what to do. We do know what to do.
Have you faced the same resistance and challenges?
Of course.
In rolling out UHC?
Of course. And I liked when Ndu says, it sounds pretty basic. What he has said is pretty basic. You know, empower the very grassroots CHV or community health volunteers or extension workers. Equip them with a small kit. And that is what we are doing in Nyeri County. We have taken one step because we understand there's that resistance. But it's just not enough for us to say, okay, there's resistance. What are we going to do? So we're going to sit here and, and just cry about it. What we are doing in Nyeri County is that we are ensuring through the UHC program, we have a kit for our community health volunteers. We have 2,510 of them scattered across the county. They are known as the village doctors, like you said, and they don't even need to have a white jacket. They're kind of known. They're kind of known, kwa mama nani uko daktari anakaa uko. And when somebody is unwell in the villages, even before they go to the dispensary, that person is called. Ukuja, someone is sick in the house. So these are in my view, these are the most important cogs in the wheel. But they are, number one, untrained. Number two, they have their own issues. They feel they're just volunteering, and for us, like, we pay them.
It's not a job.
It's not a job. So it's just, they could do. They might do it. They might not do it. So number one is train them, equip them, give them a basic kit. For us in Nyeri, we are giving them a kit that has a glucometer, glucose strips, a BP machine. That, for me, even if nothing else was in that kit, that is just enough.
To start.
And a little notebook, then give them the responsibility of walking door to door, knock, knock, kwa mama Kimani, I am here, I am so and so. I want to begin a small record in this home to take all your blood sugars and all your blood pressures. And I'll leave this card with you. You keep your copy, and I'll go with the statistics of how your blood pressures are doing today.
Right.
These are the only people who can do that. And if we sit here and begin to look at how impossible things are and the resistance, we will not move. And for us in Nyeri County, we have decided we have a big problem. We must sort it. It is our problem. These are our people.
Here's another question. Yes. How long do you intend for them to become volunteers? In this country, we work for money. Yeah? We don't do things for free. So you've told me I'm a volunteer. Yes, you've given me this kit. Yes, everybody calls me a doctor. Yes. When am I going to start earning? If you don't start paying me, then I start providing these services at a fee.
Yes. Of course, we have that.
Is there a nominal amount they're paid?
Yes, usually 500 shillings. I shouldn't really say this.
And they're volunteers, or are they student doctors, medical students?
No, these are locals, like locals. they make a little bit of money from their trainings, per diems that we pay, when every time they plug into,
Sitting
training
allowances.
and, so, but we want to call them volunteers. Now, the second step is looking at the capacity of these volunteers and seeing how many of them can then become community health extension workers. Now, these are
They can be absorbed into the system.
Precisely. Now, unfortunately, not all of them are able to be absorbed. When I did the registration for UHC, governor said to me, I want you to take this on. And I said, low-hanging fruit, I'm going to use my 2,510 CHVs. They're going to go around homes registering people for UHC, and we were doing that registration on mobile phones. And then some would tell me they have never used a mobile phone. So I said, we need to also know who are these people,
are we recruiting?
And what capacity do they have, and then how many of them can be upgraded. There's a beautiful conversation that's also been had by counties about CHVs, putting them together into sort of a bureau. A pool where we can have
umbrella
protective umbrella where they can be trained, and we can also agree with counties. If I am going to be volunteering with you 3 times a year, you're training me. I need some basic clinical training on whatever, how to take a diabetes test,
draw blood kind of thing.
Draw blood, some basic sort of training, and this training should be basic for everybody countrywide,
right? Because
there are some CHVs like those in Nyeri and Machakos that are advanced in terms of training. There are some counties that don't even have CHVs. Those ones that are about to pilot UHC. So it's about getting these people, training them, building their capacity. And I hate using the word capacity building because I think it's a little bit
cliche.
It's cliche. But ensuring that they have the capacity to do the basics in terms of healthcare. And like I said, the countries that have succeeded because of these people, because of the more outreach than the sitting and waiting for patients to come in.
If you paid them, say, a small stipend of 2,000 shillings
a day?
No, not per day. It cannot be per day. It's per month.
Yeah.
Remember, they are working with people around where they live. It's not as though you ask them to traverse the county.
They're already doing something in that environment.
Yes.
They live there.
Right?
Yes. So even traveling is minimized.
Yes.
The 2,000 might cover for a little transport if they have to move a little far. In terms of just making a provision for budgeting, is it doable?
It's. I think the PFM Act, prohibits. If people are not actual employees, and so you have to go about it in a very clever way. Like we pay the airtime, so it's called airtime for our CHVs. It's really not. It's not
remuneration for the work.
Remuneration. If we go remuneration, then you have to regularize them as your county staff. And just how much of a wage bill does that then mean? So it's a little bit of a tricky situation. That's why we're saying if we bureauize them, put them in a bureau, and then we say we are paying the bureau, then the bureau pays the CHVs.
Are they primarily youth? Are they quite young people? Could they be rewarded?
It's a mixture.
Could they be rewarded differently? So not financially, perhaps with a training course or with something else, so be innovative about it as opposed to
that would complicate matters. Keep it simple.
Politicians come in.
Just keep it simple. We would like you to do this. We will give you some airtime, and when you come for a meeting, we'll reimburse your transport.
Yes, that's exactly how we would do it.
That's how you do it.
And I can imagine that these people are people who are respected in the community, first of all.
They are.
Unknown.
So they're not the youth.
They're trusted.
Like the DJ saying it's Mama so-and-so.
It's Mama so-and-so who was a former nurse or, whatever. There's something brilliant that is happening in Murang'a County. I sat with the Governor Waria and he said, you know what I've done? I've called all my former nurses and I've told them I want to make you my CHVs.
Brilliant.
I'll give you a little bit of airtime, and these are already people who are passionate about the health space. They're not going to give you the issues, the initial issues of I'm so afraid of an injection. How am I going to do? How am I going to draw blood? These are people who are already who have been in that space. So even using some of the retired nurses and retired clinical officers, medical officers, helps. With beefing up, especially the extension workers, because that's the make or break for UHC, in my view. Yeah.
Interesting.
So we're talking about rolling this out countrywide shortly. Budget has already been allocated.
Right.
But we are saying the challenge, first of all, is for the counties to prepare themselves for this. Should we be saying that this is something that should happen to every county before you actually receive the money for UHC? First of all, have a way of vetting and checking. Have you done the basics? Have you done the groundwork? Because we're going to waste a lot of time again with all the other 43 counties are going to be piloting it for 1 year.
Yes, I think they have had a whole year. I mean, if they are not ready, they must be. They have a question to.
Maybe they need the money to prepare as well. Some preparation is needed.
Some advance.
Some money is needed. For
money would only be needed to beef up your human capital. But you need no money to connect your dispensaries to water, clean water, clean and safe water. You need no money. I mean, and if you need money, you have it as a governor, at that very level. If it's electricity, it's a phone call, So there are some that can be forgiven, for instance, if it's human capital. But there are some that,
Even knowing the number of dispensaries you have in your county
precisely.
doesn't need any kind of money, right?
Precisely. And those are the things that they must begin to do. And once, UHC comes on board, there's also dealing with the perceptional issues that now everything is free. You must actively, like for us in Nyeri, we have been actively telling them it's not everything that is free. Sometimes you will go in and drug A, B, C, and D is missing. And don't start saying UHC is not working. Or you go to a hospital and there's so many people and you start saying UHC is not working. In fact, what we say in Nyeri, when we like to see our dispensaries are full, because this tells us one thing. These are ordinarily people who would be feeling unwell, but would be so worried about the cost of care and the cost of drugs that they would sit at home until one day they just collapse and die. So the fact that we are beginning to see people feeling unwell and saying, I want to go to a hospital because I have my UHC card, is for me a great achievement for UHC. I like it when I go and see our facilities are overwhelmed. I say these are ordinarily people who would have sat at home. But today they feel confident to come and seek health care. Right.
Does the county of Nyeri have any association with the National Research Fund or the National Commission on Science and Technology in Akosti?
Not that I know of. Of course, I would have to,
why I mention it
to ask the health staff about
these bodies exist, and not many people perhaps know about them or understand them.
Yes.
But the research element within a county is something that would be important.
Of course.
If the universities aren't taking it up, you do have healthcare workers. All these people are trained.
Right.
They have an education, and some of them may actually be interested in research. So to beef up the research component, the health component within your county, these two government institutions would actually be very instrumental, and they do have funding.
That's our gift. That's our gift to you.
Thank you. The first time I heard about Nakosti was at the tail end of my PhD, when the professor started saying, "Do you have an Nakosti
approval?"
And I said, "Nakosti? Who is Nakosti?"
Like Nakada.
I can Nakada. So I can imagine we probably haven't really leveraged on the benefits of that. The truth is, if my research or my, just basic desktop and observational research tells me, right, research is not a priority, has not been a priority in the counties.
Do you think it should be?
It must be, of course.
Precisely, because
it must.
If you look at most CIDPs, and you're a researcher, just go and look at those CIDPs and first remove your academic hat and just read through them. You will see the gaps in terms of research informing decision-making and strategy for counties.
Yep.
Because you will hardly hear a reference of research was done and this is the need. Unfortunately, this is
our
where...
time is up.
Oh, dear. Politics goes before research. So it's about the politics and the research then follows.
It's amazing how research would even help that politics.
Dr. Caroline Karugu, the Deputy Governor of Nyeri County, thank you very much for joining us this morning. And thank you for, of course, in highlighting the success story of UHC in Nyeri County. And thank you for the gift that you brought to us.
The coffee. You are welcome.
Hold it.
You always hold it.
CT has not actually had a bit of a sniff of It's actually
You all must tell me if you like it.
It smells really good.
Eric, I am applying the oldest and most reliable method of data collection. It's called observation. I am observing it.
Observe it by holding it.
It's ground already?
Yes, it's ground.
It's fantastic. Yes, taking that home with me.
Thank you very much for bringing. Now you see, we are 4 of us, and you brought 2.
There's 2 more downstairs.
Very good. So yes, and then those are just the 4.
I like a woman who's deliberate.
When are you bringing the machine?
And then the machine is coming next week.
When is the machine coming next week?
The machine can actually come next week.
Next time we invite you.
Excellent.
We'll have it here.
Plungers.
Tell this Kenyan
Plungers for all of you.
We have
Kenyan
space
to
here
push
for that.
What else do they produce in Nyeri? We can invite you more often.
I know, coffee,
We will
tea,
come and visit.
milk, yogurt, and you must come and visit.
Dr. Karugu, thank you very much for joining us, and thank you for tuning in to the Situation Room this morning. It's Kenya's biggest conversation. Of course, you can join us again tomorrow morning, 6 a.m. to 10 a.m. Dr. Karugu will not be here, but we'll be having her tea, the tea from Nyeri County. Coffee, sorry, the coffee from Nyeri County. We'll be having it in the studio tomorrow when the machine comes.
Eric needs some coffee.
Yeah, I need some coffee. Have a good one from now until 3 o'clock. Of course, you have uninterrupted music, and then remember to join Monique for Spice Drive, 3 to 7 o'clock. Good morning, 8 to 10 o'clock. Bye-bye.